I have the pleasure today of introducing our next presenter, Beth Vernig. Beth is a professor at the University of Minnesota School of Public Health, Division of Health Policy and Management, formerly Health Services Research and Policy. She is a trained epidemiologist and is skilled in the use and interpretation of population-based measures of health and healthcare use, with particular expertise in the use of administrative data, such as that from all payers claims databases, or APCDs, and the Medicare and Medicaid programs. Her expertise covers the use of Medicare data alone and in combination with other data sources, including cancer registry data, data from local and federal surveys, and compiled geographical summaries. She has publications and technical reports using SEER Medicare, and Medicare data. She is experienced in the development and dissemination of best practices around the strengths and limitations of using claims-based data, including APCDs, Medicare, Medicaid, and the linked SEER Medicare data. Her title of her talk today is Using Linked Medicare and Medicaid Data, and again, we will take questions at the end of her talk. Beth, the stage is yours.
Okay, thank you very much, Lindsay. I'm going to start with a very important question. Does this look okay? this Zoom and WebEx and all of these screen sharing things are probably the most challenging.
That's good for me.
Perfect, thank you very much. I'm delighted to be here and to really talk about using Medicare and Medicaid data and the linkages and what is possible. So with that, I'm going to get going. It's going to be a little bit more about the data sources and with some examples woven in, so it might be just a little bit different than some of the other talks, just more as a bit of warning. Let's just figure out how to get my screen controls to work, excuse me. So the brief background, as we've been hearing, is that there are plans to link Medicare and Medicaid data from a couple of studies, such as the tobacco use longitudinal mortality studies, the mortality disparities in American community studies, and so on. And so what I'm really talking about today is sort of what the opportunity is from the Medicare and Medicaid side. As a reminder, Medicare is a federal insurance program for people who are age 65 and older. It's almost entirely a census there. The estimates vary a little bit with age over age 65, but the most recent are that by the time people die, about 98% end up enrolling in Medicare. It's also a health insurance program for certain younger people with disabilities. And the point here is to remind you all that this is disability as defined by the Social Security Administration, so it's not quite the same as what we might consider a disability in sort of a colloquial sense. So there are many people who have disabilities who won't be considered disabled under Medicare. So if that's a population of interest, we can chat about it. And then end-stage renal disease. Medicaid, as was brought up earlier, is a joint federal-state program for low-income children, pregnant women, parents, seniors, and individuals with disabilities. So they cover different populations and have different eligibility criteria. But what they have in common is what are called claims data. And what this is that each hospitalization, clinic visit, outpatient test, pharmacy fill results in a bill. The bill itself will contain information needed to determine whether the bill should be paid and how much should be paid, which means it contains information about who received the care, who provided the care, the dates of service, the diagnosis, the comorbidities, so the secondary diagnoses, the procedures, and how much was paid. And here I do say Medicare, and I should say the program because it's the same for Medicaid as well. When we think about claims, typically the claims will be in files based on type. And so it's organized a little bit differently than we get with some of these surveys. So there's enrollment, and that's not technically a claim, but it's incredibly useful as we try to differentiate between didn't get the service and wasn't found in the file, which can be an important consideration for inference. So how do you interpret not finding something? The enrollment information is incredibly useful there. There'll be hospitalizations. There'll be one record per hospitalization typically, and it will have the primary diagnosis, any secondary diagnosis, any procedures they had, length of stay, characteristics of the facility, and payments. So we know where people got hospitalized, why they got hospitalized, and so on. There's a hospital outpatient file, and this is a typical claims file. And hospital outpatient here is treated in hospitals or in facilities owned by hospitals, but not in an inpatient setting. So emergency room use, day surgery, and so on. There's typically also another file, which in Medicare language would be called the carrier file, and that contains physician services and services that are provided not in hospital outpatient departments. So one of the things that is perhaps most challenging about these data is that their organization is not based on inference, it's not based on research interpretation, but is based on the structure of the healthcare system and bill paying. And so we have to keep that in mind as we interpret things. And a project officer of mine from the late 90s used to say, Medicare is a tiny little insurance company that likes to release its data to researchers. And that's been a really helpful comment for me because it keeps me remembering that this is fundamentally insurance data. And so we have to interpret it, to understand it, we have to put ourselves in the perspective of an insurance company, which may or may not be a perspective we're used to having. I'm an epidemiologist by training, and I never thought that I would spend as much time as I do considering how bills are paid, but it is, in fact, a really important perspective. There's skilled nursing facility, and in Medicare, it's limited to a very short benefit. In Medicaid, it's a longer benefit. There's home health agencies. There's a durable medical equipment, so this is like walkers, equipment that is needed, CPAP machines for sleep apnea, and then there's pharmacy data. So there are these range of files that need to be put together. Now, when we think about claims data, and the reason this is for is the first one is, and especially in context of surveys, is recall bias. So one of the challenges is to get accurate information about, for example, whether a disease is incident or prevalent, when did something happen? It can be really hard, and for those of us who do survey work, we can talk about triangulating, what time of year was it when it happened? Do you remember how old your kids were? And trying to help people get their reports more accurate. But the advantage of the claims is if somebody was enrolled during the period, we know, and it was completed at the time. We have known denominators. So again, we can differentiate between people who were not enrolled in the program or people who were enrolled but didn't receive the care. And that becomes really important when we're trying to interpret not seeing something. It's much easier to have confidence when we see something, but in fact, for a lot of our studies, we also want to know what to do if we don't see something. The data follow the person, and that's really nice because that means we don't need to worry if somebody moves, if somebody moves from one area of the country to another. If they're in these national programs, we will find them. So in fact, even questions of do people move and what is the relationship between their health status and where they live, those questions are possible. The data are longitudinal, which means we have them over time. This can create some analytic problems, which others have mentioned, where you're trying to get the claims in the survey to line up so you know what was known before and what information was after a survey. But with the dates and the longitudinal nature, that is completely possible. So if we think about a person with a hip fracture, just to sort of take an example, we know whether they're in Medicare, we know their demographics, age, sex, race, we know their residency at the zip code level, so we know where they live. We know their date of death if they died, and we know what happened to them before their fractures. We know their pre-existing comorbidities. We know whether they had cancer, whether they had heart disease, whether they had AFib, whether they'd been getting their flu shots. We know things about them. We know ambulance services, so we can find out how they, that's how they got to the hospital. We know the details of the hospital stay. We know major complications. We know rehabilitation. their home health care, any consults, their medications. So you can see we know a lot about these people. And so the challenge sometimes is putting it all together into a story because it's almost overwhelming, or it can be easily overwhelming about how much data you have. There are things we don't know about Medicare and Medicaid. We don't know the exact physical location. So a lot of my colleagues are talking about geocoding. I would love to be able to geocode Medicare or Medicaid, but we do not have street addresses. We have zip codes. And in urban areas, that might be sort of manageable, but particularly when we get into rural areas, you know, a zip code centroid is not the most precise measure of location. We have a problem with left truncation. So in other words, the time prior to enrollment is missing for people who enter the Medicare program when they turn 65. We don't know what happened to them. So we have to either require a washout period or guess or not focus on incident versus prevalent. Within Medicaid, there also may be enrollment gaps. One of the things that's a common pattern is that people get Medicaid, they don't get all their paperwork filled out, they lose their Medicaid, health problem happens, they get re-enrolled, and you get this sort of this chunky, gappy sort of experience. Well, those gaps, we won't see what happened to them when they're not covered. We will only see when they are. There's no information on non-covered services, and likewise, there's no information on covered services where they don't submit a bill. And examples are going to be plastic surgery, which is typically not covered, or a recent example in my family is, while Medicare does cover scooters, there's a long backlog, so they decided just to buy it rather than wait for a Medicare provider to come through. In that case, we will not know from looking at the claims that my relative has a scooter. There's no information on treatment intent. We don't know why they did something or why they didn't do something. And that can be hard if we're trying to do inference and trying to interpret not just what was done, but why it was done. Related to that, there's no information on test results. So we can see a test, we can see a screening test, and we can see what happened after the screening test. But we have to be careful in our interpretation. So, for example, if we see somebody who has a mammogram and then we don't see anything happening after that mammogram, we can assume that the mammogram was negative, but it's also possible that it was a positive mammogram that nobody followed up on. So those are things related to that. Just in today's paper in Minnesota was a report about several hundred COVID tests that were positive but were never reported to the provider. In the claims, those people will not have COVID. Nobody will go back and fix the claims. There's very low to missing information on behavioral risk factors, and that's one of the things that I'm personally most excited about. Smoking, obesity, other information about people and what they do that may change how they interact with healthcare or what healthcare they need. And again, we have indirect measures only of income and education, and as was discussed earlier today, those measures can be quite problematic. So why link? And again, the answer is really, I think, simple, which is surveys have tremendous detail about things, risk, diet, lifestyle behaviors, subjective and objective parameters of physical and cognitive function. And so being able to put those together is a tremendous asset. Examples of linkage are the SEER, and I apologize, this is long, SEER Medicare linkage, which has linked cancer registry and claims data, the Health and Retirement Survey to Medicare, Project SHAD, which is done by the Institute of Medicine, which linked occupational exposure during the Vietnam War with health outcomes later, the Women's Health Initiative. And the SEER Medicare is an example I'm going to run through a couple of things with. So it has incident cancers, diagnostic staging, first course of treatment in very high-level measures, and survival. Overall, about 96% of people 65 and older in SEER linked to Medicare. So what we end up with is information about incident cancers, information about their treatments, and we can put things together. This first study I'm going to show you is looking at, this is work done by one of my PhD students, And what we were asking about is, do people make different treatment decisions for breast cancer depending on how far they have to travel? As the first paper in this series, we looked at urban and rural women, and we showed that the actual travel distance, the mean one-way travel time, is about 3 times farther for urban women than rural women. So about mean of 15.4 miles versus 40.8 miles. Likewise, the distance to the closest facility, so is 4.8 miles in urban areas and 21.9 miles in rural areas. If you think about radiation being 5 days a week for approximately 6 weeks, this 15 miles each way starts adding up. So we ended up estimating that the average rural patient logs about 2,600 miles and 55 hours of travel over their treatment. This is a huge difference, and it does make us question whether or not some of the treatment decision-making is based on health or whether it's based on their ability to manage this travel. Another example of a study that we have done is looking at hip fracture as an example of cancer treatment. And the question we had was whether radiation therapy for pelvic cancers resulted in hip fractures. And if you can sort of imagine thinking about the anatomy, the hips are in line with the radiation fields for anal, cervical, and rectal cancers. And so the question we were asking is, does the radiation cause damage to the bone? And we can see the top line, so this is percent with a fracture. The dark is irradiated, the lighter gray is non-irradiated. And we see for all 3 cancers a significantly higher rate of hip and pelvic fracture for women. This is all women, in fact, for women who received radiation for their pelvic cancers than for women who did not. This is a sort of question that the linkage makes possible, and without the linkage, we really couldn't do. So, linking these cohorts provides tremendous opportunities. I've got to admit that listening this morning to the other surveys, I was very, very excited about the possibilities of linking Medicare with some of these survey data and what it will allow us to do. And I am excited about having our sessions tomorrow and continuing these possibilities. You just remember, as other people said, we can extend outcomes, we can identify risk factors, we can identify information on loss to follow up, we can take a cross-sectional survey and put it into a longitudinal context, minimize loss due to physical or cognitive impairment, and again, more efficiently use these resources. I am not going to talk about the Research Data Assistance Center because I think I am over time, but just as a quick note, we're a contractor with Centers for Medicare and Medicaid Service that provide free assistance for researchers interested in using Medicare or Medicaid data. And the piece of it all, our website is there, and the piece of it is that we do have educational offerings, including workshops. So if you're thinking about using a linkage, taking one of our courses might be valuable or helpful. And with that, I apologize I went long, but do you have any questions?